Yeah, good afternoon, everybody. My name is Ulrik. I'm the CEO of Human Bytes, a Danish company specialized in bringing AI to the European healthcare. And we have running this AI Academy where we're having a number of different sessions to bring inspiration, new perspective, and concrete use cases to audience across Europe here. We operate within a number of different specialties from radiology, acute care, ophthalmology, patient monitoring, digital pathology and radiotherapy, mammography and cardiology, and have done a number of implementations, especially across the Nordic within those different areas. Today, we are focusing within radiology on the prostate part of it with the webinar. I just need to of today, where we have David from Quibim to host a 10-minute presentation about a short demo, and then especially we have around 20 minutes for Dr. Vilanova, who will introduce himself a little bit later, but also give some customer experience from our clinical practice. Just while we are at this one, I just want to promote a few sessions we have upcoming in our webinar. We have a digital pathology, April 23, looking into AI and especially biomarkers with the MSI and HER2-low directly from the H&E slide. We're looking into the future breast cancer screening with our partner from ScreenPoint and their transparent solution with, again, some real-world experience from two sites across the Nordics. In May and June, if you sign up for our newsletter, you'll also get for neurological disorders, MRI, PET, and SPECT. Radiation oncology, a customer from Norway, will explain their user experience with our solution from Therapanacea. We'll have a fracture detection, a customer testimonial, and we'll also have a legal perspective, some of the new EU regulation with MDR and exceptions, etc. And then also we had a few historic that can be found on our LinkedIn page, especially the latest one, radiotherapy, from Nikos, CEO of Therapanacea, who did a really inspirational session around the current and the future impact with AI for radiotherapy. So that was just a short introduction from Human Bytes here, and I will quickly try and pass it over to you, David. Can you share your screen here? Good afternoon, David.
Yep, absolutely. Thank you very much, Ulrik, for the invitation. Let me know when my screen...
Yeah, we see it.
Perfect. Well, thank you very much. And as Ulrik mentioned, my name is David Basagio, and I'm the product lead here at Quibim. And today I will be giving a short introduction as to why we decided to focus on prostate cancer and what we're doing in this space, and present a little bit more about the features of our product, QP-Prostate. But before actually jumping into what we do in terms of technological development with QP-Prostate, I actually wanted to provide a bit more background for those less familiar with prostate cancer and how actually AI can help in the prostate cancer pathway. So the diagram that you see here, it's the usual journey that a patient would go through for a definitive prostate cancer diagnosis across Europe and other countries. So it usually starts with patient-reported symptoms, given that there is no national or European screening program, such as in breast cancer. So patients could actually self-report to primary care with particular symptoms, such as difficulty passing urine or blood in the urine. And the general practitioner will order something called a PSA test, which is a blood test. And if this shows a high level of PSA levels, then that patient would undergo a prostate MRI. That prostate MRI will obviously be assessed by a qualified radiologist. And if there are any suspicious findings, then a biopsy will be performed for a definitive diagnosis. And the two key challenges with this pathway or this journey are essentially two main bottlenecks. The first one really it's around the use of PSA as a preliminary step for the MRI. The main problem with PSA is that it really lacks suboptimal sensitivity and specificity. So this essentially means that it doesn't catch all the people with prostate cancer that actually could need treatment and intervention, but it also flags potential people as having prostate cancer when in reality they're perfectly healthy. This has actually been shown in different studies, but I just wanted to highlight two here. One performed in the UK through the Reimagine group led by Dr. Shonit Pungwani, where they actually found that around half of the patients that did have cancer, they actually had completely normal PSA levels. So this essentially could mean patients that could completely go unnoticed at this step, could not progress into this pathway, but could actually have a clinically significant prostate cancer. And the second one, it's a very similar study in a Canadian population showing very similar results. The second bottleneck, it's in the pure radiological assessment. And prostate MRI, it's actually characterized by relatively long reporting times compared to other organs. There is a high interreader variability, and there's obviously a shortage of radiologists across Europe who can confidently report prostate MRI. And I actually wanted to focus on these latter two. So what you see here to actually exemplify that variability across different readers, what you see in these graphs are 26 different US sites. So you have those in the y-axis. And what you see here, it's the positive predicted value that those sites had when reporting a PIRATS 3 or a PIRATS 4 lesion. So this essentially, it's what are the chances that that patient did indeed have a clinically significant prostate cancer when a PIRATS 3 or a PIRATS 4 lesion was actually being identified. And what you can essentially see here is the spread on this positive predicted value across different sites. So if you were to go into center 1, that probability would actually be only 20% compared to up to 70% for site number 26. So this really exemplifies the fact that depending on the radiologist, depending on their experience and their clinical practice, the variability to detect clinically significant prostate cancer is actually very, very wide. The second one is around radiologist shortage, which I'm assuming this comes as no surprise to anyone in this webinar, the fact that there is a widening gap between the supply and the demand of radiologists. And just to exemplify what this actually means for prostate cancer, these are data from NHS England in the UK, where you can see that the 28-day target for all urological cancers. So this essentially means from the time the patient is referred from primary care to the moment a definitive diagnosis is actually being given, stands only around 55% of the patient cancers. And this target should actually be closer to 75, 80%. So there is a lot of room for improvement and room to actually try to speed up this process. So with this in mind and have taking the fact that this is what the landscape looks like in terms of prostate cancer detection, what we have developed at Quibim, it's QP-Prostate. And this is essentially a software that it's intended to improve the radiologist's workflow when reporting prostate MRI. What we do with QP-Prostate is first a pre-processing step to essentially register the diffusion and the contrast sequence against the native T2. We also perform a quality check against PIRATS guidelines, again, trying to really homogenize and bring together the acquisition protocols that different centers use and give actionable insights in terms of what are the parameters that should be changed in those centers to be able to be PIRATS compliant. And once we've done all this pre-processing step, we actually performed an automatic prostate segmentation, which is divided in the peripheral, transitional zone, and the seminal vesicles. And last but certainly not least, we perform an automated lesion detection that is trained on pathology data. And I will be delving into this particular feature a bit more later on. These results get automatically generated as a secondary capture, and they're directly sent back to the PACS so that they can be seen by the radiologist at the time of reporting. So what you see here, it's on the left that prostate segmentation encompassing the central and transitional zone in red, and in green the peripheral zone. And on the right secondary capture, you can see that lesion contour with the identified lesion that it's suspicious to be clinically significant prostate cancer and on the right-hand side. Delving a bit more into how this lesion detection functionality actually works, what we use is a biparametric input. So we take the actual T2 that you see here on the left, together with the DWI sequence, and we do generate is an ADC and a B1400 DWI map. We combine this with the actual T2 and the prostate segmentation, And what we perform first is a clustering step. What we do perform in this clustering is identify potential lesions within the prostate based on similarities in intensity profiles across the T2, the ADC map, and the B1400. So this step here is self-supervised. It doesn't need any manual annotation. It's purely based on the characteristics of the own image. And once this clustering step is being performed, what we actually have to do is classify and to actually see how many of these potential lesions are actually indeed clinically significant prostate cancer. For this step, we actually use the biopsy results as ground truth. So we take any lesion with a Gleason 7 or above as a positive for clinically significant prostate cancer, and everything else gets discarded. So in this case, then we would have, in this particular example, 2 lesions that are clinically significant prostate cancer. And then finally, what we perform is a post-processing algorithm to provide an indication on the level of risk. So this is essentially similar to how radiologists provide a PIRATS 3 to a PIRATS 5. The algorithm provides a 2-tier system to provide a high versus a moderate level of confidence on that particular lesion being a clinically significant prostate cancer. The way that you can see this, as I mentioned, you can see at the top a lesion that is marked as a high suspicion of being clinically significant prostate cancer, and the one below, highlighted in yellow, a moderate lesion of being clinically significant prostate cancer. It is also worth mentioning that the software actually takes into account where that lesion is, so it actually distinguishes between the peripheral and the transitional zone when detecting these suspicious lesions. And this is, again, to really take into account the fact that most lesions actually do appear on the peripheral zone, and that they're actually morphologically very different in terms of the appearance they have in the peripheral versus in the transitional zone. I just wanted to quickly show you a demo on how this would look on a normal pack. So you could have here all the natural sequences that you could encounter in a normal prostate MR exam. And then the ones that we provide here, you can see that the lesion segmentation gets overlaid onto the native T2, and the radiologist can readily see where that lesion is and draw their attention to actually consider whether that lesion is indeed clinically significant prostate cancer or not. We also provide quantitative information for the lesions identified by the software. So in this case, you can see that we provide this risk category that I was just mentioning. We also provide the size in the actual dimensions, as well as the lesion volume. And we provide the number of slices where that lesion is present, as well as a snapshot to readily identify the lesion that this quantitative information is referring to. That's everything from my side. So more than happy to now give the stage to Dr. Kai Vilanova, so that he can give you an overview on his experience using the platform. So Dr. Vilanova, all over to you.
Okay. Well, thank you very much. First of all, while I'm going to upload and to share my presentation, I don't know why, but the camera cannot. It's not allowed to me to show it, but I'm going for the moment to share. Well, can you see? No. Do you see? Because what do you see now?
Yeah, we can see your screen. So I think, yeah, if you put the presentation, we should be able. Yeah, we can see it fine, Kai.
Okay, but you don't see my the camera, no?
No, not your camera, but we can hear you loud and clear, and we can see the presentation.
Okay. Yeah. Okay. Then, well, first of all, I have to thank, of course, Quibim and Bytes for inviting me to share and to provide what's my experience during the last months, since I have and I'm using this tool that David has shown in order to try to improve our detection of prostate cancer using this AI tool. So during the following minutes, first of all, just a brief introduction, and then what I'm going to show, and well, already precisely David has shown, but it's important to remind how today we can diagnose a prostate cancer using MRI. And then what's the workflow, how I'm going to provide in my report that there is a suspicious lesion in this examination. And what has been in these last months when we have included this tool. So how has changed the workflow implementing this QP-Prostate tool that I will show this in clinical cases that we have read, and then we have shown, and we have provided the final results. So in order to compare what has been our practical use of this tool. So here is the picture. So here is the blue. Here is the prostate cancer. Here is the world of prostate cancer. So as much blue, dark blue, so much incidence. So what is clear is the important health problem of prostate cancer as we can see, and of course variability according to the different location. But of course, if you are in Europe, so we have to take in mind how common is prostate cancer. High risk of prostate cancer, 60% of men will have prostate cancer. And of course, this is the figures that we have in Europe. And as I'm working in Girona, so northeast of Spain, so I have to deal with my figures. So 1 on every 7 men in Girona, in the region of Girona, it's about 1 million population have prostate cancer. So the most common cancer here in Girona is prostate cancer. So big problem. So the good news is the survival. So survival is almost 90%, 5 years. So this is the good news. But nevertheless, we have to check and we have to detect this prostate cancer because there is a big health problem. So we know today, and at least in Europe, there is clear recommendation in the clinical guidelines. What is the recommendation? The recommendation, as we have seen, as David has shown. So the pathway starts whether there is a high PSA. So whether there is a high PSA, the clinical recommendation is clear. Before any biopsy, an MRI should be performed. Then I have to read this MRI. Then I have to decide. Because whether there is a positive, what's a positive? A positive because there is a significant lesion. And then what it is clear is that I have to place a needle where the MRI has shown this lesion. And this is how I'm going to improve to detect the significant cancer. Whether I can see the lesion in the MRI, whether I can place the needle, and then I'm going to detect significant cancer because what I want is to avoid to detect non-significant cancer. So this is the optimal pathway to detect the significant cancer today, at least in Europe, the clinical recommendation. And David has shown already what's the pathway, but this pathway has different steps, and each step has to be optimal. What does it mean? This means that the first step is to acquire a good and an optimal MRI acquisition. So then I have to read, and I have to read properly using PIRATS. This is the guidelines that I have to check what is the criteria and to decide whether I'm going to score this MRI. But after my evaluation, I have to provide a report, and this report has to be structured. Otherwise, the biopsy is not going to be effective, because otherwise, the final step is going to be the diagnosis. So if one of these steps is not optimal, we are not going to diagnose a prostate cancer. So how important is all this pathway, all these steps has to be optimal. Otherwise, there's not going to be effective diagnosis of prostate cancer. And we know prostate MRI. Prostate MRI, it can be multi or biparametric, but at least biparametric means that T2 and diffusion has to be optimal. And not only diffusion, but we have to read a post-processing series that is the ADC. So that means that these are the most 3 important images that I have to analyze. And of course, these are 3 images, but each image is a series, is a sequence. So in this case, it is hundreds of images that I'm going to scroll and to analyze whether there might be a significant lesion. And this is going to be important to perform a good and a high quality acquisition with MRI. Because finally, after my evaluation of this high quality MRI, I have to decide what's the chance to have a significant cancer. And this is how, whether I'm going to decide whether this patient has high chance to have a significant cancer, whether there is a PIRATS 4 or 5, because this might be a significant cancer. And this is going to be important. I have to know the knowledge what is the criteria to decide this is significant or not? Whether there is a Bytes 1, 2, 3, 4, 5, because each score depends on the criteria. And as has been said previously, it is important for the prostate to separate the peripheral zone and the transition zone, because each zone has different criteria. And I have to know the knowledge in order to decide whether there might be a significant lesion, a Bytes 4 or 5, or non-significant lesion, Bytes 1 or 2. And this is going to be important to provide my final report. Because whether my final report is a Bytes 1 or 2, the clinician, when receives my report, this is going to avoid a biopsy. But whether the clinician receives my report that is a Bytes 4 and 5, this patient could have a significant cancer and requires a biopsy. But it is important also because whether I can provide a Bytes 3, it is not clear. Might be significant, might be not significant lesion. Then I have to include also other clinical features. And whether there is low clinical suspicious of significant lesion in this Bytes 3, probably we can avoid biopsy and we can perform a follow-up. But the same lesion, a Bytes 3, but might be more clinical suspicious, and I should recommend a biopsy. So this is going to be very important because it's not only the interpretation of the MRI, it's also the interpretation of the patient, because the same lesion might change my report according to the condition of the patient. So there is different features that I have to combine before I provide the final decision of my Bytes. And this is going to be very important. So let's go to clinical practice. Because first of all, I have to upload also all the sequences, as David has shown. I'm going to scroll. I have to review. It's going to take time for the analysis. I will display the most important sequences as I'm showing now, the T2, different planes, diffusion, ADC. I'm going to scroll. I'm going to see that this patient, 67, not very high PSA, not very high suspicious. The density is also going to be very important to analyze before I place my final decision of the Bytes. Here, the PSA density is 0.12, so it's quite below the cutoff that is suspicious whether there is higher than 0.15. So I'm going to scroll. A small prostate, quite heterogeneous in the peripheral zone, not clear focal in the diffusion or ADC. So if I'm just going to check and without any good detail, I'm going to spend time, and probably if I'm not expert, I could miss. But if I have, and now I place the series that Quibim has provided, Quibim shows me, here might be. And when I look carefully, probably, now I see some focal, 5 millimeters on the right side of the peripheral zone, on the right side of the peripheral zone. And when I check, and it's very important to perform the window level to adjust, and it's not easy with the ADC and the diffusion, because these sequences and this post-processing requires to provide, because otherwise I'm not going to check, as this could be difficult, high signal, low signal. So now I can be more confident that this is a white signal, high signal on diffusion, low signal on ADC. This is the criteria in the peripheral zone that this I'm going to report a Bytes 4. And this Bytes 4 requires a biopsy. And this is where the needle I placed in these 5 millimeters. I took one sample, and the sample, it was effective because significant cancer. And this is the final step as we saw from the pathway. So good acquisition, good report, final effective biopsy. Because now, again, not very clear suspicious for clinical because it's just a slight over 4 PSA. But here, a slightly high PSA density because it's over 0.15. The prostate also is not quite big, heterogeneous on 32, But of course, we need ADC, we need diffusion. So here, it's less than 6 millimeters, and less than 6 millimeters sometimes could be non-determinate. So it is low signal on ADC, high signal on diffusion. So this could be, of course, the criteria that this could be significant. But after reviewing all the case, and now, if I just have the image, that QP-Prostate allows me to be more confident that even it's very small, 5 millimeters, but it provides that this can be significant. So my final report is a Pirate 4 because less than 1.5 centimeter, high signal on diffusion, low signal on ADC. This is the criteria of the Pirates. So now my final report is a Pirate 4. So the biopsy should be performed. So the needle is in this specific location. So prostate cancer in this 5 millimeters peripheral zone lesion. This is PSA of 7. This is quite a more large prostate. Peripheral zone, quite heterogeneous. Transition zone, no clear focal lesion. So if the peripheral zone, in this case, in the diffusion or ADC, there is no lesion. And in the T2, this is important because we have to know that the Pirates for the transition zone has to analyze the T2. If the T2 is not a lesion on T2, this is going to be a Pirates 1. So if one asks me, do you see something in the transition zone in this image? There is no lesion. What's the Pirates? The T2 is the sequence that I have to evaluate the transition zone as a first step. If the first step is normal T2, this is Pirates 1. So this would be my Pirates for the transition zone. But now, of course, I have to check the diffusion and ADC for the peripheral zone. But the peripheral zone, there is no lesion. But now the diffusion and ADC shows me a lesion in the transition zone. But Pirates says me that whether T2 is normal, diffusion has no role. So now what I do? Because I see something that could be suspicious from my knowledge, but according to the guide, this is normal. Okay, let's see. Now I have the additional information. And clearly, this is a significant lesion from this additional tool. So I'm going to provide what is also my experience. And also I have additional information that my final report, even this is against the Pirates. Against the Pirates, I provide a clear Pirates 4. And now the needle. And the needle is clear a prostate cancer in this 7 millimeters lesion in the transition zone. So this was against the rules, but this was a significant lesion. Let's see another case, important case, because this patient already we know 8 years ago, this patient was diagnosed, as we can see, previous MRI, biopsy, prostate cancer. The patient had radiotherapy. Now, 8 years later, they request an MRI because after radiotherapy, the PSA was 1.2 and now is 5. So this is what we call biochemical recurrence. So there is suspicious that they might be a lesion. Okay, so let's do the MRI. So here I see where it was the original, but this is atypical because it has an annular shape. So this is not typical. It is not described in the Pirates. It is not described in the guidelines that also we use after radiotherapy or prostatectomy. So this is annular restricted diffusion, but it is not described this annular. So then this could be suspicious. Let's see what the QP shows that this is moderate. So I have to check the guide that we use for after radiotherapy, and even it is not described this annular shape, but I can be more confident if it shows that this is a significant lesion. So my final report also is this might be a recurrence. So what's the next step? To perform a biopsy. So again, the needle within this lesion and the final diagnosis, you can see that the lesion even it's increased from the previous diagnosis. Let's move to another example, because here it's not very high PSA, but here we can see a high PSA density, more than 0.15, as we have to know from the PSA density cutoff. So the T2, it's not clear, suspicious, some asymmetry here, but the peripheral zone, we know it, we have to analyze the diffusion and the ADC. The diffusion is high signal, and here this is what we call discrete. So whether we see discrete signal intensity, either in ADC or in diffusion, this cannot be a 4, because we have to know the criteria. A Pirates 4 is whether there is markedly high or markedly low. So here it's not markedly low. So here, according to the Pirates, this is a clear Pirates 3. So this is not clear suspicious. So as I said previously, what do we recommend in a Pirates 3? Well, here we have to combine also this clinical information. This is over 0.15, so probably this would be more suspicious than what we see in the images. So let's see what is the criteria from this tool. And here also, it provides that this could be a suspicious lesion. So this Pirates 3, remember that the outcome or the recommendation depends on the clinical condition. So I could be more confident now that with all this information, I'm going to recommend a biopsy. And this is what, at the end, we did, of course. And the needle, it was clearly in this location, and the significant cancer was the final decision. So this is clearly a significant lesion, although it was not a clear Pirates 4, as we can see from the criteria according to the Pirates. And now, this is not very high PSA, not clear suspicious for the PSA density. The T2 is not clear lesion. We might see high signal on the right side, not very clearly marked, because here in the left side also we can see, and also the ADC. But on the right side, then whether we perform the contrast, this would be without contrast, probably a Pirates 3. And now, in this Pirates 3, we can perform contrast in order to decide if this is positive or negative. And it is clear positive, the contrast. So the Pirate is clear. If you have a Pirates 3 and you have contrast and this is positive, you have to upgrade. So the Pirates is clear. The report in this case should be Pirates 4. And what's the suspicious according to the QP-Prostate? No suspicious. But what I'm going to do, because according to the criteria of the Pirates, this is a Pirates 4. So my report is a Pirates 4. So what's the next step? Next step is a biopsy. So next step is take the sample. And the sample is negative. But it's important to know what is, if it's really a negative prostate biopsy, because we have different pathological conditions that might be positive on MRI and negative on the biopsy. And this is one of the conditions. This is what it was in the pathology report. This is a lot of inflammatory cells. So a lot of the inflammatory cells can provide focal prostatitis. In this case, positive MRI, negative biopsy. And here there was no suspicious in these two. So this was my experience that I wanted to share to you in using in these last 3 months this tool. So for us, it has provided an assisting tool, important assisting tool, because it has also allowed us to take decisions in order to provide whether biopsy, and of course, then it's going to change the treatment of the patients. Not only, of course, that it assists in this the final decision, but of course, it's going on. This has been also our experience that this automatic display, just in a few seconds, that I have this new series, this additional tool, that it provides less time in our analysis in this workflow. And of course, we know after performing different evaluation after several hours, of course, I can be tired, but of course, this tool can provide whenever it's necessary all this information. And even these small lesions that we have seen several lesions in these different examples, it is important that I could meet these small 5 millimeters lesions that we have seen, and then if I miss, it will increase the time that afterwards it will be diagnosed that this prostate cancer. And we have seen in the previous lecture that David has shown, there is a huge variability in the analysis of the MRI because different experience, different. So if we have a tool that it's more consistent, then we can improve this variability and we can reduce the variability to interpret MRI. And of course, we have seen some cases that even we can avoid some biopsies. So if we avoid biopsies, less cost, that this tool can provide at certain point more cost effectiveness in this workflow. And of course, how amount of data provides any examination of MRI. So if we have to deal with a large volume of data, we cannot afford of this as a human, and then this data can be analyzed automatically, and also we know that this data can be also used as a biomarker. So at the end, in this practical use of this AI tool that we have been using in the last months, but it is sure that it's a good and improvement accuracy to diagnose. If we improve the diagnosis, then the patient outcome it will be better. At the end, the impact is for the healthcare efficiency, because what's the final outcome is for sure to improve management of prostate cancer. So this has been my experience, and thank you for listening. And now I can provide and take a time if you and we can discuss, of course, all what you can consider. Thank you very much.
Thank you, Kai, for a very impressive presentation here with some clear and tangible outcomes. If there are any questions from the group here online, please write them in the chat. The session is recorded and will be uploaded for you to preview or send to a colleague. Maybe I can start with a question. In terms of implementing this solution from an IT perspective and organizational change management, any recommendations or do's and don'ts?
Well, well, this is a very important question that you are performing now, because whenever we are dealing with any technological software that we have to implement in our daily practice, we know that everyone, or it's a very variable, the PAC systems that we are going to use, and my PAC system that I'm reading this examination that I have shown you, this is going to be different from the one from the hospital nearby or whatever hospitals that today. So what is important is that these tools have to work and have to be, because otherwise, and have to be, in this case, quite easy to easy at the beginning. It's not easy, because this is also has been my experience that it took time. So there is a previous task that it has to be performed. Well, in this case, as with, of course, this tool with Quibim and with the IT system of my clinic. In this case, that it took time first to all the different details that, of course, has to be in the implementation. And then, of course, whenever it's starting, always there is some difficulties. But I must say that after several days, that of course sometimes it was some. But in the last well, more than 2 months since the starting, there's no problem. So after just several times after the examination has been finished, that it has been pushed, let's say, to Quibim, the analysis has been performed, then returns to the PAC system, and less than half an hour after the examination has been performed, we have this result that I have been showing with this information that it's going, and this is how today we have incorporated now without any problem. So important first to dedicate time to implement, because sometimes it's not easy, but now my experience is perfect use of this tool. Yes.
Thank you. We have a question from Philip Greenfield here asking about the reimbursement for this tool in Europe. I can answer for the Nordic, where you have public procurement where there's no reimbursement. It's part of a sum zero game where you have the budget and don't get any reimbursement. But for Spain and the rest of the world or rest of Europe, Kai, any comment from your side here?
Well, this is one of the key issues also, and whenever we are talking of AI tools, this is one of the big debates. And well, as well, I have a quite experience. I'm almost 30 years since I'm a radiologist. So, and I remember, for instance, because I have already, and I'm using also some CAD systems, especially, for instance, for the breast MRI. And whenever I implemented these tools, for instance, CAD systems for breast MRI, so this was well, the reimbursement from the companies, from the insurance, this was not allowed. So then, well, this is something that it's the additional that as a department that you provide additional information, but it's as we have said, this is for the patient. So this is probably no returning. But what we have to provide at the end is that this is an improvement for the management of prostate cancer, because probably we are not going to return in this case, but probably we are going to perform more prostate MRI. So this would be, the cost-effective probably that we are going to have in our department in this case, if we are going to implement this tool. Yeah.
Thanks. And maybe a last question for me, if nobody else on the line here, in terms of a generalizability of an AI solution like this, that's often a discussion. So to introduce this solution in another country in Europe, would you expect to see similar accuracy and sensitivity and specificity, or any thoughts here on the generalizability?
Well, as any tool that it's going to be, well, this question again, it's very interesting, because whenever we implement, of course, I'm having, and I have quite a bit experience on prostate MRI. It's more than 20 years since I'm performing prostate MRI, so quite experience. So the experience is going to be important, also whether these tools are going to be implemented. And I think at the beginning, it's important that any experienced radiologist using it has to be also validate. So it's important to validate it on its own department, besides that the tool has been validated in other locations. So I think it's important that because the variability could be, even the tool reduces variability, but of course it has to be interpreted, and at the end the radiologist has to take the decision. So this is why it is important to manage, beside the validation of each tool that has been provided in elsewhere. But I think what it is also important is the local validation, in order to have a universal utility of this tool.
Thank you. David, you have a comment here on observation?
Yeah, I just wanted to add here that we obviously take generalizability seriously at Quibim when we clinically validate this type of tool. So for this particular lesion detection algorithm, we validated it in a patient cohort spanning 6 different countries, spanning Philips, GE, and Siemens scanners at both 1.5 and 3 Tesla. So we try to obviously be as diverse as possible with the patient population. We obviously appreciate and acknowledge that in any specific local settings, things may be slightly different to the ones that we use for our clinical validation. And that's why we're always keen on post-market surveillance studies, and actually trying to really understand how the tool may particularly behave in a specific center. But from our perspective, that's something that we've always taken into account and considered from the early days when we started validating this particular tool.
Thank you, David. And I think that's also our recommendation from Human Bytes, that whenever you introduce an AI, that the first weeks or months you do some quality controls and make sure it performs according to the expectation in a prospective way, so you get a real life experience and validation.
Okay.
I don't know if there are any other question on the line here. Otherwise, I think time is also up. Again, thanks a lot, Kai, for joining.
Thank you.
Apologize for the problem with the camera.
Well,
maybe it's the setting my end I need to work on. But really inspirational, and I hope people on the call had a good session.
Okay, thank you very much. Excellent.
Thank you. Bye-bye.
Bye-bye.